everyone, and welcome back to It All Starts Here. This is a podcast focusing on the education and communication of reproductive science and women's health. I am your host, Olivia Moyer, and we are here at the Institute for Women's Health at UCL here in London. And today we are going to be diving into the topic of an organ that I think is incredibly special and underappreciated, which is the placenta. And really just talking about its critical role that it has in all of our lives and development. And to discuss this, I have with me today the lovely Professor Eric Jonio, who is a researcher here at the Institute, but as well as that is an internationally established fetal medicine specialist with extensive experience in the related bioscience. His academic work and clinical activities have been focused in placental and fetal development, and the diagnosis and management of placental-related complications of pregnancy. He has covered the full spectrum from the anatomy and physiology to the diagnosis and treatment in utero of placental and fetal diseases. So it is so lovely to have you here with me today.
Thank you.
I think maybe to kick this off, it would be great to hear from you how you started down this path and about studying the placenta and, have become so invested at looking at this organ over the course of your career.
Thank you for the nice introduction. I mean, like good things, it all happens, a little bit as an accident to start with. And as a child, I remember my father telling me that he saved my life when I was a fetus in utero, because he was very much anti-medicine. Not that he would not have a vaccination, he was not an anti-vaxxer. Really, probably one didn't exist at the time. But my grandparents on the maternal side were doctors, so they were getting samples from the pharmaceutical industry. And when she was pregnant, of course, she had a bit of headache, nausea. So her parents would give her these samples, which my father would throw in the bin immediately because he saw that homeopathy was much better than any of these terrible medicine. And so I grew up with that concept that maybe medicine can harm you in utero. And, it was fascinating. And then at high school, I saw a documentary by an extraordinary professor of biology who was fascinated about in vitro fertilization, IVF. And I was absolutely gobsmacked when I saw the birth of Louise Brown and Robert Edwards and Patrick Steptoe, who were technically, medically the father of Louise Brown, not biologically, of course. And when I went to medical school, I went to the professor of embryology. So the sort of combination of, fetal malformation, how they develop in utero, and the possible role of the placenta in transferring this medicine. And the first chapter of any embryology book or anatomy book is actually the placenta, because without the placenta you have no pregnancy. So that's how I got into it, and I've never stopped because it's such a big chapter that I've just managed to come out and become a fetal medicine specialist. But I know much more about the placenta than I know about the fetus.
That's so cool. I really do relate to that kind of. I think for me, it all started with the interest about how it all begins. And over the last couple of years, I've really just become so curious about the placenta and really just how important that in utero period is. I mean, I was doing some research that I mentioned to you back in Toronto, looking at, an artificial placenta, and just from that, it became clear that there is so much that you have to consider and the influences of that. So I guess thinking a little bit about the study of the placenta, I mean, the evolution, you touched upon how people would start to consider the influence, obviously, in utero and how that can impact you throughout your life course. But maybe you can talk a little bit about how the evolution of studying this organ has gone and the different ways that we can investigate it and into today.
I mean, us humans have a unique placenta, which is very different from all the other mammal species, except maybe the higher primate like the gorilla and orangutans. But because they have a different lifestyle, obviously, and they don't exclusively walk on two legs like we do, that placenta develops in a different way. When we have a very special development of our circulation inside the womb, because we walk upright on two legs, and so that changed a little bit the interaction between the placenta and the womb. And so this problem actually is the source of most of the pregnancy complication, because it is so complicated that the other animal species, mammals, including the higher primate, don't have things like miscarriages as often as we do. They may have a few percent of miscarriages. We have 20-25% of pregnancies that implant that don't make it. And then you have other disease like preeclampsia, which is completely unique to human species. I mean, you can mimic this in other laboratory animals like rodents, but it's never the same because they have a different placentation, they have a different traction, and the immunology also of these animals is different from ours. So this is combination of this vasculature that's different and the immune interaction between the placenta and the uterus that makes us so different. So not easy. And in a way, I'm quite happy because I would not have liked to be involved in animal experiment anyway. That here I had an endless source of tissue for research because nobody wants to keep placenta, and so it's being thrown away at the end of the delivery. So the research has been very interesting. So the main problems are obviously miscarriages and this preeclampsia, which is a hypertensive disorder of pregnancy, which can lead to premature delivery, to very small babies, because placenta stops functioning at that stage. So, I mean, these are probably the most important complication of human pregnancy.
Right. Yeah, I mean, I think it's obviously using different models to try and understand it can be helpful, but yeah, since being here, it's definitely been interesting to kind of be able to look at it from the human side of things. And I guess that's also something that, as researchers we're conscious of. It's useful, obviously, to use the different models, whether it's a cell line or, in some cases an animal model. It's helpful to understand, but it's important to recognize those differences, and particularly with placentation, I mean, the different ways that it can occur. I guess kind of taking more of a clinical background or trying to understand, how that all goes, in your work in clinic. What have you found to be true, over the course of your career, or solid facts, if any, about influences on placental health? What do you think is important to know and consider?
I will start with the untrue first.
Sounds good.
Because if you open these old traditional anatomy textbook, you'll see that as soon as the blastocyst implants and the primitive placenta, the early placenta, starts forming, you have an entry of maternal blood inside that placenta. You see this in those diagrams, you have a little bit of red color coming inside the placenta. And in fact, this is not true. Because it takes time for the placental cells to adapt to oxygen level that we're breathing, even if there's less inside the tissue than there is in the atmosphere. You don't get 21% oxygen inside the uterus, you probably get 10-12%, but even that is quite high for an early pregnancy. And so what happens is the placenta, during its development, actually blocks the entry of the maternal blood inside itself, to allow it itself to develop properly, so that when the time comes, which is usually at the end of the first trimester, around 12 weeks, 3 months, then progressively maternal blood can get in. And that is the primary mechanism of the miscarriages. In all miscarriages, at some point, you have a premature entry of maternal blood inside the placenta, that it is due to a chromosome abnormality, that it is due to an infection, that it is due to genetic cause that we cannot always identify. It's this premature entry of maternal blood inside the first trimester placenta that creates the phenomenon of miscarriages. And not surprisingly, patients who have a miscarriage most of the time present with a bit of bleeding or a lot of bleeding to an A&E department. It's one of the most common complications, in medicine in general, but of course it's the most common complication in pregnancy. So that's, that's untrue, and I'm very proud to say that, Grey's Anatomy, the team of Grey's Anatomy have accepted this concept, and then for the last 3 editions, I've been here with a colleague in Cambridge, Graham Burton, to write a chapter on the placenta. So finally, this information is getting through, medicine and science, and so it's changing a little bit the way we look at patients with these complications, the way we manage them, and finding treatments in those cases that don't have a chromosomal abnormalities and maybe would benefit, from not having a miscarriage. Because of course there are other causes like immune cause and vascular causes that can be improved with treatments that are no evidence-based.
Right. I mean, I think obviously it can be hard to understand or to take an interest in understanding different processes related to health if it's not kind of something that you naturally have a curiosity about. So, with the placenta, I think generally people maybe don't. I think that's why it's so, I think underappreciated, is just because unless you're pregnant, I mean, it's not something that you really care to understand and study. But I guess I'm wondering, in clinic when you have new moms that are coming in, or, they're early in pregnancy, are there certain misconceptions that you find that they, or questions that they have really about the placenta and, or their baby, or an understanding that they might benefit from about the placenta?
No, in general, people are not interested in the placenta, though they don't realize they wouldn't exist if they didn't have a nice, healthy placenta when they were fetuses in utero. And I can say it's almost the same in the medical establishment, because fetal medicine looks at the fetus, and they often forget the placenta is a fetal organ. And so they rarely have an interest in looking at the placenta, even when you have serious complications, like placenta previa and placenta accreta. And they tend to forget that ultrasound imaging was actually first used in pregnancy to locate the placenta, not to identify fetal malformation. It took another 10 years. We're talking about here the end of the 60s when the first placenta previa were identified, and this was a killer, because if you didn't know the placenta was previa, which means the placenta is covering the neck of the womb, if you go into labor or someone examines you, you induce a massive hemorrhage, which before you had access to modern technology was very difficult to control, and most of the patient would die. So ultrasound has really had a much bigger impact, in fact, by identifying this kind of placental anomalies. There's another one which is less well understood by the public, because placenta previa, I think everybody knows what it means. It's the mole of pregnancy, the hydatidiform mole, which is sort of genetic anomaly of the placenta, and basically the placenta starts growing madly with other fetus. It can transform into a cancer, and this again was not diagnosed until the patient was presenting with heavy bleeding, abnormal blood pressure, and no ultrasound can identify this from the second month. And so it has saved countless lives, just identifying these two placental anomalies, because placenta previa, the nasty one, between 1 in 500 and 1 in 1,000. And mother pregnancies, if you look at miscarriages, most of them miscarry, it's probably 1%. This is far more common than all the fetal anomalies put together. And of course, fetal anomalies rarely have an impact on the mother's health. Well, these anomalies are really a killer, and in low-income countries where there is no ultrasound examination, this is a killer every day. So yes, no. So they are not misconception. I don't think people are really having any conception at all, because they don't realize how important the organ is.
Right.
I mean, yes, there's a lot of crazy things happening with people, and it comes in waves, fashion, eating their placenta. And I know that, it's back, and I get that question in clinic. But then if the other function of the placenta, apart from, enabling the fetus to grow and develop normally is to prevent too many of the bad stuff to get through, like pollutant, maybe microplastic, we're still studying, but black carbon particles seems to get through, but certain medication, then it's able to stop some parasite, but not others. So understanding this is very important, but eating it makes me wondering if I tell the patient in general, think about your local swimming pool and the filter, that cleans the water.
Oh God.
And basically, you want me to eat that? Are you serious? I mean, it has, fortunately, acted as a barrier for a lot of the bad stuff which have piled up. If you take, for example, smoking, still about 20% of mothers who smoke. Up to 5 cigarettes, it doesn't really have an impact on the fetal growth, probably because the placenta is capable of blocking horrible stuff like cadmium that's in your cigarette smoke. But then after some level is reached, if you smoke 10 cigarettes a day, you can see then the impact on the fetal growth. But then all of this has piled up in the placenta, and imagine everything we have in the air, in the water, or in what we eat, piling up in this. I mean, I don't understand the concept, because if you transform this into a pill, you dehydrate the whole stuff. So the molecules like progesterone that might have an effect as an antidepressant, for example, which is one of the arguments used, to eat your placenta, is gone. They're not biologically active. They've been completely destroyed by the process of transforming this into chips, crisps, and pills. So all you're left with are all these horrible, toxic, molecules. Seriously?
Yeah. Speaking of which, again, another one of the many kind of incredible talents of that organ is the ability to act as a sort of barrier, kind of filter, which we don't totally understand what and how and what gets through. But, through your research, something that you've brought up in courses is this idea of, and I think it's important in all of the different fields, is to really take a step back and consider whatever it is you're studying in the context of the environment now. And that's important. That's something that we've been trying to do better in different fields. But, you've brought up this point about microplastics and different bits that can exist in the water. And something that you've touched on before is, obviously we have to continue doing work on understanding the environment and the interactions between an organ and the environment. But taking it to water, you have done research and you've talked about this. I wonder if you could dive into that a little bit.
Water, the problem is the molecules that are in water, pollutant, like arsenic or nitrate, they do cross the placenta quite easily. Historically, they didn't exist until the modern age. Exposure to black carbon particulate matter, which is what you have in exhaust pipe from cars and factories, etc. In a way, we've been exposed to this for a very long time, because you're burning wood in a cave, you're exposing yourself to these particles. So, no, I think it's what we were discussing before, the level of exposure, the amount which overwhelms the placental barrier function, if you want. That is really the issue that we have now. We have created the problem, and we don't yet know what the long-term consequences are going to be, because we are the first generation of people who are exposed to such an amount of pollutant, and certainly the first generation that are exposing the unborn generation to that amount of pollutant, because we are all exposed to it. Even if you live in the countryside, we've seen the water pollution in the countryside is as bad, if not worse, sometimes than it is in big cities, because it's totally uncontrolled, and sewage is going into pristine rivers and on beaches, and so this is new. We don't have enough data, but I'm sure that's a question of time. I saw the World Bank UN report showing, that half of the planet doesn't get access to clean water, doesn't have sewages. And this is so simple. I mean, we had this in Roman time, and it worked. So, stopping cars is not going to happen overnight. Stopping water pollution and getting everybody access to clean water. Yes, and there, that's where the placenta, of course, my interest in the placenta comes in, is role as a filter, but how much can the placenta take?
Mm-hmm. Yeah, no, I think it's mind-blowing, like you said, how, still today, access to clean water is something that not everyone has, and actually an alarming amount of the population doesn't have access to.
And it's so cheap.
Yeah.
Of course it costs money, but nothing compared to, changing all the cars into electric cars. The investment is minute compared to what we spend on arms and, factories that are polluting. And
yeah.
We can't create water. The number of water molecules on this planet is limited. There may be some more deep inside the Earth. We might get some from Mars, but we can't create it.
Yeah.
So we have to respect it.
Mm. And, I mean, I've seen that you've done obviously a lot of work internationally and, taking this further than the water, but, your studies and your practice in different countries where access to healthcare as well is really limited. I mean, the one of the goals of this podcast is really to improve science communication. And you have done a lot of work with the charity that you co-founded back in 2006 of Medical Aid Films, which, I'm sure you can go into more than me, but is dedicated to help medical training and education in those low-income countries. And I guess I wonder, how do you find, and where did the idea of using these films to teach as a teaching resource, where did that come from? And how do you find that translates in different countries?
It comes from the BBC, which at the time was without any doubt the best television in the world. And the documentaries that were being produced, this wildlife documentaries or historical documentaries were absolutely fascinating. I was wondering why we're not using this in school, for example, or in education in general, because some of them, are absolutely stunning. I mean, you learn, even in science, you learn when you watch them, even at my stage. And so I thought this sort of approach was probably the best one, because people are not going to read anymore. And if you think about, low-income countries, mainly in Africa, not many of the nurses or healthcare assistants, the people that really need to have access to this education, read English, French, or Portuguese. They may understand it, but they may not read it. And so access to book also is limited. When we started, there were not many smartphones in Africa, except in North Africa and South Africa, but in between it was almost empty in terms. No, you have 2 smartphones per African in sub-Saharan Africa. So, passing on this knowledge through films that you can translate easily with AI, one of the advantages of AI, into all the different languages, including local tribal languages, is fantastic, because you can really democratize access to education. So obviously our films are very basic, where we're talking about placenta previa, which obviously is a problem. One of the major problems is placenta retention. So it's not a placenta previa, it's not blocking, because otherwise the mother dies if she doesn't have access to a team that can do a cesarean section. It's a placenta being left behind after the baby has been delivered. And so you can't leave it inside the uterus for too long, because it will be responsible for bleeding, heavier bleeding. It will increase with time, infection. So that needs to be removed. And it affects 2 to 3% of the population. It's not. And it's probably one of the main causes, with the uterus not contracting properly after delivery, of maternal death in the world, but obviously mainly in sub-Saharan Africa. So yes, another important item about the placenta, which obviously we've been making films about it, and anybody can have access to these films through YouTube. Some of the more technical films are protected because we don't want the general population to start doing cesarean sections at home. But preventing postpartum hemorrhage, basic resuscitation of the newborns, malaria prevention, HIV prevention, breastfeeding, all these important things, identifying patients with high blood pressure, preeclampsia, which is much more common actually in African population. All this is available online, and link with equipment, for example, measure the blood pressure that are very cheap, or measure the oxygenation level for newborns, that local nurses, midwives can get through NGOs and other charity organizations. So, we've been teaming up also with some of these charities that are providing this sort of affordable equipment. So, it's a globalization now. So, and again, it doesn't cost much money. It's incredible. Yeah. Making a film like this probably would cost between $10,000 and $20,000. And it can go a long way. Some of our films have been watched 1 million times a year.
Wow.
For specialist films, it is quite unique.
Absolutely.
We need support. We need more help because we need to make... My dream would be to make an entire midwifery curriculum online, translate in all the possible languages we can translate into this. So, that midwife, because in many countries it's not a midwife, it's a nurse, and in other parts of Africa you don't even have nurse, you have a healthcare assistant, the traditional birth attendant. And we could give them a sort of basic training through these films.
Right. Yeah, I mean, and even taking it, back to the whether it's, of course, teaching as a concept in pregnancy, but for the patient too. I mean, just helping to shed light, I guess, on the importance of the placenta and the importance of nurturing a healthy placenta during pregnancy. I think there's so much utility of having a kind of video. I mean, at least personally, I think I always learn better when I can see kind of the way that it works rather than just reading it out of a book. So I think it would be great, of course, to continue that on. And yeah, I mean, I think the future of these different areas, whether it be teaching clinicians or the patient, there's going to be a lot that evolves in that area. And I think videos is definitely a way to do that. Okay, well, I mean, it's been so lovely having you here today to talk about the placenta, and you guys heard it here first. Don't maybe skip eating it after you give birth. But it was such a pleasure, and thank you so much for joining me today.